So our final speaker on the conference is called Reason. He's co-founder and CEO of Repair Biotechnologies. He has been an active angel investor in longevity industry since earlier days, participating in the field since early 2000s. He is also a founder and writer of important news and commentary website called Fight Aging. Reason, we're happy to have you here.
Hi there. So I'm going to talk today about cholesterol, but not the usual view that your doctor propagates. Something novel that we've been doing that leads us to a novel view of cholesterol, and we believe that certain aspects of cholesterol should be counted as a hallmark of aging. So we'll start with a brief introduction. Cholesterol is both vital but also a problem. So cholesterol in your body, it's needed by every cell. Every cell uses cholesterol in various ways, such as to make up the cell membrane. In most of the body, cholesterol is really only created in the liver. You get about 80% of it from your liver, 15% from the diet. A little bit is created in the brain as well. And it's then transported everywhere through this really difficult transport mechanism. And the mechanism gets bad with age, and a lot of other things get bad with age. But the consequence that we care about is that you get these local excesses of cholesterol, not the transport per se that's the problem, but you in tissues like the liver, the brain, the pancreas, your blood vessel walls, you get too much cholesterol just sitting around in that tissue. Now, despite the fact that every part of your body needs cholesterol, every cell needs cholesterol, the unmodified cholesterol is highly reactive. It's actually toxic. So cells make it safe by esterifying it or by putting it in the cell membrane or by handing it off, but they only have so much capacity to do this. So it's very easy to overwhelm this. A large part of why a fatty liver is damaging is because there's too much cholesterol, there's more cholesterol than cells can handle. So you get this free cholesterol. Free just means unmodified in this context. A free cholesterol molecule is an unmodified cholesterol molecule. This is an undruggable target because cells can't break it down. So you can't make a small molecule drug that gets rid of excess cholesterol from inside cells. That's very hard. And you can't bind this cholesterol effectively because any drug that could bind it would attack cell membranes and other vital sources of cholesterol. So people really haven't looked at this as a target. We have, and it's very clear that this excess cholesterol toxicity, is contributing to basically everything that obesity makes worse. And a lot of these things are also age-related. So cholesterol is not just an obesity problem, it's also an age problem, this impaired distribution of cholesterol in your body. So we at Repair focus on atherosclerosis, and that's where most of our data is, and most of the data supporting this contention that cholesterol is actually not just a mechanism, it's a very important mechanism. Now, a brief primer for those who don't know what atherosclerosis is. This is the buildup of fatty plaques that weaken and narrow your blood vessel walls. And when they rupture, you get a heart attack or a stroke. But even before they rupture, they're causing harm by reducing blood flow. So this is a universal mechanism, and it's not just people with high LDL cholesterol. Most people who show up with a heart attack or stroke in a hospital, they do not have raised cholesterol. It is totally normal to get atherosclerotic plaque. Nearly everybody has it to fatal degrees when they get older, and it kills a quarter of our species. It would kill a lot more people if cancer was curable. So the problem with this plaque is that the current approaches to therapy do not regress it. They only slow it down a little bit. So the whole business of lowering your blood cholesterol, it only really slows down plaque growth. It doesn't regress plaque growth. So you have big studies, big epidemiological studies of tens of thousands of patients taking statins for years, showing that the average regression of existing plaque is zero. That's why this is a chronic condition. It's why it kills so many people. We can't cure it yet. But what we have shown, and this is important evidence for the importance of cholesterol, localized excess cholesterol, is that if we selectively only remove free cholesterol, we can reverse atherosclerosis. And the way we do this is by generating a fusion protein And that fusion protein is engineered to only break down free cholesterol. How we do this is super behind NDAs and intellectual property, but it's very clever. And so long as you have a gene therapy that can express this protein in the cells you care about, you can get rid of the cholesterol from those cells totally safely, no side effects. It just works. So we have a couple of different drugs, and I'm just telling you this so that the rest of this doesn't get confusing. We have Rep3 and Rep4, and they're basically the same. They're both lipid nanoparticles delivering messenger RNA that causes the expression of our therapeutic protein. And Rep4 is a much, much better version, one that was more recently developed. It has an improved mRNA sequence, and that becomes important later when we're talking about some of this. But here is essentially how we work to reverse atherosclerosis. We deliver our drug to the liver, only the liver, and the liver is where cholesterol is made largely in the body. So when the liver feels like it has too little cholesterol, which is what happens when we break down as much excess cholesterol as we can, then it starts working a lot better. It becomes much more efficient. It dials up everything it can do to pull back cholesterol from the rest of the body. So this toxic free cholesterol, provided you can remove it from the liver will then pull it back to the rest of the body to the liver, where again, it's broken down by a drug. So it's like pulling a plug in the bathtub. All the water goes in that direction. And this additionally has the effects of reducing inflammatory signaling. And the combination of this reduced inflammatory signaling to enable cells in the plaque to start to clean up the plaque, and the removal of fat and cholesterol from the plaque to make it more stable and shrink it, and then remove the excess garbage from the liver. This combination of things produces very dramatic, very rapid plaque regression. And I'll show you how dramatic and rapid it is. In 6 weeks of treatment in mice with severe atherosclerotic plaque, you see a 20% reduction. If you could do this in humans, there would be no more heart attacks. This is a huge effect size and very, very rapid. And this tells us something about just how important plaque is to how important cholesterol in the liver is to the process of aging, because it's disabling your natural mechanisms of plaque regression. And it's not just the heart. You see this in the aorta as well. That picture on the left there is a sliced aorta sliced lengthways and then stained for plaque. And you see, a real 20 to 30% reduction in the count of small plaques. So this happening in the aorta, it happens everywhere throughout the vasculature. It's a tremendously broad and rapid effect. The mice have much better livers, as indicated by serum ALT. Aniline transaminase is a marker of cell stress and cell death in the liver, and it's reduced dramatically. So these mice have greatly improved livers. Additionally, we can demonstrate that actually we're taking the free cholesterol from the rest of the body and moving it back to the liver just by removing it from the liver. The liver then, does all it needs to do to make the rest of the body hand off as much of this free cholesterol as it can. So HDL goes from the periphery back to the liver, and you can see we dramatically increase the amount of free cholesterol, toxic free cholesterol we're moving back. But then that free cholesterol that returns to the liver is not then getting sent back out again. Normally it would. The body recycles cholesterol aggressively because it's very expensive to make, but it's not going out again because we break it down. Now, we've conducted non-human primate study that we recently finished. The data is still processing. But we have some initial data from the study that finished a couple of weeks ago, and we saw no adverse effects in the monkeys. But the interesting part here is, okay, we also start to see a reduction in serum ALT, which again is a measure of liver stress. So we see that the treated monkeys are looking better by week 2 than the untreated monkeys, and that the pastel range here, the blocks, that's the normal range for monkeys. So we're down at the lower level of the normal range for monkeys on a high-fat diet here. Now, we also see the same increased free cholesterol transport back from the periphery to the liver, which tells us that this is probably going to regress plaque. And stay tuned, we'll have that data in a couple of months. Interestingly, in the monkeys, the more efficient version of our drug is clearing enough free cholesterol from the liver that it does actually dramatically reduce the amount of free cholesterol that's leaving the liver to go out to the rest of the body. So this is a bonus. We don't see this in mice, but this is a bonus in monkeys. This should additionally reduce the impact of cardiovascular disease in people who are treated. So we hope that this will show up in our patients when we get to patients as well. And very quickly, so the conclusion here is I just showed you a bunch of things that nobody else can do. Nobody can produce these effect sizes on free cholesterol via any existing means. Nobody can regress plaque to the size we have and the degree we have in the preclinical models. So this should tell us something about the role of cholesterol excess. And of course, in our future, we'd love to apply our therapy to different diseases in different parts of the body and hopefully demonstrate that we can reverse conditions there as well. But you see the pattern here for a hallmark of aging. You see there's some sort of damage that they're underlying. We've no idea what that damage is, how it connects to cholesterol metabolism. You can hypothesize, but nobody's done the work. So you get the disrupted cholesterol metabolism, you get the localized excess of cholesterol that causes toxicity, and then you immediately have, after that, atherosclerosis, liver disease, neurodegenerative diseases, which are very strongly connected to excess cholesterol and dysfunctional lipid metabolism at this time, and all sorts of other problems as well. There's a big, big, long list. Every disease that obesity makes worse that has some component in it of cholesterol toxicity and normal aging for people of a normal weight. And the important point here is that, okay, it's not just a marker. You can actually use this as a target to dramatically reverse age-related disease, certainly for the ones we've tested, which is atherosclerosis and metabolic dysfunction-associated steatohepatitis. Our ability to restore the liver is quite dramatic. But a good marker of aging, a good measure of aging is one where if you turn it back, you get rejuvenation, which is functionally what we get here. If you want to argue that reducing the size of your plaques and making them more fibrotic is a form of rejuvenation, I think it's certainly curative for atherosclerosis, which is what we want at the end of the day. We want to stop a quarter of humanity dying from this condition. And with that, I'll stop there and happy to take questions from the group at large. And remember to unmute this time.
Thank you very much, Reason. We're really happy for your research and work. So now I ask the audience for questions. Yes?
Thanks for the talk. Very interesting research. I'm curious, assuming that this works in humans, how would you use this, and how would it replace the current cholesterol management tools like statins, or would you combine this somehow? How would the world look like after this is available?
Well, we're complementary to all other therapies. So at the end of the day, if you have something that slows down atherosclerosis, then that's useful. And nobody's going to stop trying to lower LDL cholesterol in people who have high LDL cholesterol, particularly when the drugs become generic and become very cheap. PCSK9 inhibitors have a great future ahead of them because they don't have many of the side effects of statins. And once they're generic and cheap, I think they will continue to be widely used. But the therapy in humans, we anticipate to be 8 weekly infusions as a course of treatment. And then it will be up to the clinicians to decide how often do you do that. But let's say for the sake of argument that 1 8-week course of treatment produces a 5% reversion of plaque volume in humans. If that was true, then a normal human could use this therapy once every 5 or 10 years and just never develop atherosclerosis, provided you started sort of by age 50. If you have a mutation and you have some form of familial hypercholesterolemia, at worst, maybe you use it once a year. That's the sort of play we see happening in the future as an add-on to other therapies though I guess we should argue that the other therapies are actually more of an add-on to what we're doing here, which is the primary goal to reverse disease.
All right. So will this therapy be available to like normal people, or in the beginning will it be very expensive?
Oh, absolutely very expensive in the beginning because we're taking the rare disease path. We're initially planning to go through the pipeline for homozygous familial hypercholesterolemia, which affects 1 in a million people. And the reason for that is not the money; it's because it's faster to get to a point at which you can prove that this works in humans and get an approval for it. What will actually probably happen is that as soon as we have a phase 1b trial done with good human data, we will be acquired by a pharma company that will do their best to get this into as many people as possible as soon as possible, which would mean starting phase 2 trials in parallel with the rest of the homozygous familial hypercholesterolemia trials. And they would focus on probably acute coronary syndrome, peripheral artery disease in ordinary people and run quite large trials to prove out the market there. So, but in any case, this is not a fast industry. This is not a fast business. It's definitely some years from where we are now before this would be available in any meaningful way, even through things such as the right to try law in Montana.
Thank you very much. One more question from Didier Cornell.
Yeah, first, it's not really a question. It's to say how much I admire your work for fight aging since so many years. But maybe to have a question is, what do you think is missing at the moment to have more information and more cooperation in the longevity movement? What could we do?
Yeah, that's a tough question because we've always, as a community, I feel that we've always struggled with actually moving information around, and that's not unique to us, of course. That's always been a challenge. The scientific community struggles to explain itself to the public at large. And how do you fix this problem? And can you fix this problem given that most of the world isn't very interested in science? They may be interested in living longer, and they may be interested in curing their age-related diseases, but that doesn't translate to an interest in science in any given way. And I don't have a solution to this. I think 20 years in, and I don't know how to make this better other than do work on new technology and let other people figure out what to do with it. I think at the end of the day, I come down to the idea that technology determines society. If you have the technology, everything becomes easier because then people will fight over it and talk about it and want to use it. But if you don't have the technology, then most of the talking is useless.
All right. Thank you very much, Rizan. We are happy that you are here with us in Ljubljana.
Happy to help.
Thank you.
Thank you.